Welcome back to the Black Health Lit podcast. I'm your host, Rachel Ray Crowder. I know it has been quite some time, guys. I have been busy and I have been resting and I have been taking care of some of my own health issues. So rest is resistance and recovery is unnecessary. I've been practicing what I preach. But I am back, and it is Women's History Month, and so it makes sense that today's episode focuses in on Black women and HIV. You'll hear from me and Dr. Maranda Ward, whose work has touched on issues such as urban youth identity and maternal mortality, to teaching empathy to health professionals and combating the social conditions that produce structural racism and violence. Recently, Washington, D.C. Mayor Muriel Bowser has appointed her to fill the Ward 8 seat on the D.C. Commission on Health Equity. She is accomplished. Do you hear me? Check out the episode description to learn more about Dr. Ward and connect with her. Today we're talking about HIV, and the reason for that is because as of 2020, nearly half, about 43%, of HIV diagnoses and deaths occurred in the Black community. Recently, too, research has shown that 1 in 9 women were unaware of their HIV infection. To combat this misinformation and stigma related to HIV, it is so important now more than ever to be informed. I hope you enjoyed today's episode.
All right. Oh, okay. So, thank you so much for the invitation to talk about HIV and, how it actually disproportionately impacts Black women.
Absolutely.
But, before we even jump into okay, let's understand the statistics and, really where we stand. I think it's important to just back up a bit and just provide, what's the state of HIV in general? Because that provides important context for how we're affected,
Yeah.
Okay. So the thing is that actually overall new cases of HIV have actually steadily gone down since 2015. I don't feel like a lot of people know that.
No, I did not know that.
So that's actually really great news. And actually, that's one of the things I'm going to talk about when we start to think about some of the strides that have been made, since 1981, the very first case that we saw. We've come a long way medically. We've come a long way. We still got a long way to go when it comes to stigma and the other social factors. But anyways, the key word, though, when I talked about the fact that the, number of new cases have gone down, the key word there was overall new cases.
Yes.
And if we look at new cases for Black people specifically, those rates have actually remained stable over that same time period, right?
Yes.
And so, okay, well, where do Black women come in? Well, I will say, as a Black woman myself, here I am talking to another Black woman.
Yes.
This is why, you probably invited me to have this conversation because you probably have seen the statistics.
I have.
In fact, yes, right? So I just really get incredibly alarmed when I read that, yes, Black people, we make up 13% of this country.
Yep.
But we're actually representing 40% of new HIV infection.
Yes.
And if we look at Black women specifically, we make up 58% of those new cases.
Yes.
That's actually double that of white women, and that's triple that of Hispanic women.
Uh-huh.
So Black women, literally, yes, we're making up the majority of new cases among all women, though men actually do remain the largest group of people that are diagnosed with HIV. Now, let me take a look. Let's go ahead and put a pin on Black women. I'm gonna come back to it because I think it's really important to understand, okay, you just said that Black women have the leading number of new cases among women. So why, kind of have this conversation about men? Well, men, they actually have the highest proportion of new cases. And, the one that actually has the highest proportion of new cases are men who have sex with men.
Right.
They actually make up 66% of new HIV cases, though they're only 2% of the population. Okay.
Yep.
And you'll notice that, I didn't say gay men. I didn't say bisexual men.
Yes.
And that's because the CDC actually focuses on sexual behavior.
Yes.
Not identity, and rightfully so, because some men who have sex with men actually don't think of themselves as gay.
Yep.
They very well still may be having heterosexual sex with women.
Yes.
And so now we can circle back, right? So this is a very important point because the overwhelming majority of new HIV infections among Black women are actually from heterosexual contact.
Yes, they are.
Okay, so, and, I also think it's worth noting that when I do share this data on women, this actually does not include transgender women.
Right.
And that's because the CDC actually reports them separately. But we
Mm-hmm.
do know that Black transgender women actually have even higher rates of new
Yes.
HIV infections than Black cisgender women.
Yep.
So again, like I said, of all women, yes, Black women are the ones with the leading number of new cases. Now, we may be wondering, well, why? Like, what is
Yeah.
contributing to why we would have the leading number? Is being Black the risk factor? Absolutely not. It's never been about race. It's
Uh-huh.
always been about racism. Let's be
Talk
very
about
clear.
it. It's
Yes, yes,
talk
yes.
about it.
Yes. So it's really important that we tease that out, though, because if we don't, we really do run the risk of profiling Black women. And so, we think about racism, which is very well documented in the literature, right? And how racism leads to bias, racism leads to discrimination. And not only does bias and discrimination affect access to healthcare, it affects access to everything else, right? Quality education, quality safe housing,
Right.
but literally, yes, physical access to healthcare, the facility, the clinic, the hospital, let alone financial access, right? Through insurance. But even if you do get there, how are you treated when you get there? Right? Are they adequately screening and testing you? And I know you said you have a background in breast cancer, right? So we know that there's a disparity with Black women, even though white women are more likely to actually even get breast cancer because they actually have the breast cancer gene.
Yep.
They actually have the highest actual survival rates. So it's kind of like, wait a minute, if you're more likely to get breast cancer and you're surviving, that's actually great news. That just goes to show you again the marvels of medicine. But the thing is that Black women are not benefiting from that high survival rate. Even though we're less likely to get diagnosed, we're more likely to die. And again, that's why I said we have to talk about how you're treated when you get there and if you're adequately screened and tested, because Black women are not benefiting from early detection and screening. So when we finally do get the diagnosis, I'm talking about breast cancer in this case, right? When we finally do get that diagnosis, either the cancer's already spread and metastasized, or it's like in a more aggressive form. So the thing is that this is not even limited to breast cancer. We can take out breast cancer and insert a range of other conditions. Literally, this is why, again, HIV is on that list too, right? So we're not adequately screened and tested. And so this actually is the reason why I'm doing the work that I'm doing around HIV disparities and the model that I'm going to introduce to you, because we really need to, have a standard set of questions that every patient is asked, because without it, there becomes a missed opportunity, right?
Absolutely.
So, Black women are not offered prevention like PrEP, which is the pre-exposure prophylaxis, which is the daily pill that you can take if you're HIV negative, but you're having sex with someone who may have exposure to HIV, right? And so take that. And again, that we have the data that shows it's incredibly effective. But that's the thing, though. There's only one PrEP pill. There's an injectable that's actually been approved by the FDA for use by women. But another pill was actually approved in 2019, but it was only tested and approved for men. So the reason why I've been bringing that up, because we also have to talk about gender oppression and representation in clinical trials, right? So there's literally 3 PrEP options for men, but there's only 2 options for women. It's kind of like, this is just like a snippet of the fact that we need representation in trials so that we can actually have options when it comes to therapeutics.
So let's pause there. So I heard you say a lot there. So first off, to just level set on the background, we're talking about HIV among Black women because obviously we know we don't make up a majority of the population, but we're making up a majority, almost 60% of new HIV cases. And then also you highlighted something, men who sleep with men. There's a whole department at the Centers for Disease Control and Prevention, the CDC, that focuses on men who sleep with men. And it's important to note that doesn't necessarily mean that they have a gender expression, identity, or identify as LGBTQIA+. It's simply the action and the behavior of having sex with another man. And then you also hit on something else. It's not race. It's not being Black that makes us, higher risk. It's racism. And part of racism is those things you talked about, like access, which is social determinants of health, our access to literature, our access to good doctors, housing, affordable housing, good quality food, etc. And so that's a great segue to talk about PrEP. which I've seen PrEP on benches and billboards throughout my neighborhood.
Yeah.
I know a little bit about PrEP, but can you talk about go a little deeper on why PrEP is important for Black women?
Yeah, PrEP is really important because it allows for Black women to, take charge of their health, right? Right. So since the thing is that, if you think about the fact that there are some Black women who may be experiencing intimate partner violence, so that is the reason why it becomes hard to negotiate a condom.
Yeah.
So it's kind of like, what, if you are if you have no matter what the type of relationship it is, right? If you are, engaged in sexual activity with someone and you don't know their status, because that's what this is basically about, right?
Yeah.
You don't know their status. Hopefully you, and through this conversation, I'm promoting that it's really important to know your status as Black
Absolutely.
women, to make sure we have a medical home, go see PCP, actually have, testing. And it's right now the recommendation is you get tested every 3 years. But if you actually are engaged, if you know that you are exposed to HIV, you need to get tested more regularly, right?
Yeah.
So like annually and up to, every 3 months, depending on the type of exposure. But nonetheless, you don't know their status, right? It's like, okay, we are sexually active, so let me go ahead and take this PrEP, right? This daily pill. You don't got to work. You can do it discreetly. You don't have to worry about bringing up the condom, and now there's a whole conversation. And again, I will say, and without judgment, everyone has a range of dynamics that are going on in their relationship, right?
Absolutely.
So, like, PrEP does provide that protection for you when maybe you don't feel comfortable, bringing up the condom, saying no to sex, or all the other ways that you can prevent HIV. It's like, okay, I'm going to still have sex with this person, but at least I know that I'm taking this pill and I won't get HIV from them, right?
Right.
So it really does allow Black women to have some agency and bodily autonomy without having to, bring in the partner. And again, I'm not suggesting that. I think that it's incredibly important, in an idealistic way to obviously have conversations with your partner, right?
Yes.
It's important to, one, feel safe and have those conversations, being able to say, either no, I don't want to have sex, or if we're going to have sex, I need to know your status, or we need to use this condom.
Absolutely.
But we also have to be real. There's just going to be some people who are not going to use condoms, right?
Yes.
There's going to be some people who don't want to bring it up, right? They feel uncomfortable. They don't feel safe to bring it up. Okay, for all of those factors, you can go ahead and use PrEP, and then you ain't got to worry about that exposure. So I feel like it really does provide, and we don't have, and like I said, the science actually shows that it's incredibly effective. And that's where, people may have questions about, well, what about the side effects? And
that's our big question. Exactly. All the time.
Literally. So that goes back to, like we said, Black Health Lit, like being literate, right?
Yes.
So you having health literate, you having those conversations with your PCP, and I say PCP instead of doctor because everybody got different clinicians that they see. For instance, my PCP is a nurse practitioner, right?
Yeah.
Whoever it is that you see, pose those questions to them, right?
Absolutely.
Okay, so, you know what? Am I a good candidate for this? Why not? How is it going to work? How is it going to affect me? How do I, like all the things, all the questions that you have. Pose those questions, have a medical expert weigh in and give you feedback, and then you can basically, like I said, take charge of your health from there. I think that's so important, because one of the last things we didn't talk about is the fact that, from a biology perspective, like cisgender women actually are more physically susceptible to HIV because of our anatomy, right?
Okay.
So it's actually easier to transmit HIV through heterosexual vaginal sex. And then, like I said, there's the other issues, the ones we're talking about, stigma and feeling embarrassed to go buy a condom, or feeling ashamed or scared to get the HIV test and things like that.
Yes.
So that's why, we have options, right?
Yes.
There's PrEP, there's condoms, there's not having alcohol, there's regular testing, all of the things. So please, again, like this, again, I love the concept of Black Health Lit, because it's incredibly important to ensure that Black women, Black people really have the tools that they need to really take charge of their health.
Yeah. And that's what it's all about. And you hit on something that probably would surprise most people, especially cisgender men, and not realizing the violence that women face, Black women especially face, when they say, whoa, you got to put a condom on.
Yep.
And so the reality is, not to be so graphic, but the reality is you may be laying there, one step from penetration, one moment away from penetration, and you say, hey, put a condom on. I've experienced it. Hey, put a condom on. And then it's physical violence, verbal violence, emotional violence. And so that is the reality of sexual encounters sometimes. And so PrEP, if someone were to take PrEP, and choose that as an option if they don't feel safe or for whatever the reasons. It is a good alternative. And then something else that you hit on is having those conversations with a primary care provider or your PCP and being honest.
Yeah.
So I just watched on Netflix the Some More comedy special.
It's on my to-do list. What you think of it?
I like Some More. Okay. She looks good.
Yeah.
But in her special, she talked about how she went to a new doctor and, they make you fill out the paperwork. Mm-hmm. And it's like, how many drinks have you had this week? Or how many sexual partners do you have? And she said she put one for everything. And it was funny, but it's also like when you go talk to your doctor, be honest.
Right.
If you're being, because if you're having sex with just your husband or one partner, boyfriend, whatever, then that's one thing. But if you are, like you said, having a greater or different level of exposure, make sure you're informing your provider so that they can be a better provider for you. Help them help you.
But another thing that I want to bring up when you just mentioned that, oh, you're married. So this goes back to like the CDC guidelines. I'm not sure if everyone's familiar that the CDC put together a set of HIV screening guidelines for clinicians, so they actually know, okay, who should get tested, right? Right now, the guidelines are saying anybody between the ages of 13 and 64 should be offered an HIV test at least once in their life. So first of all, those guidelines need to be updated because risk doesn't work like that, right?
Right.
One test at one point in your life, okay, so now you're good, like you're not,
right? Nah.
Right, so risk don't work like that. So this is, if you're having sex, there's always a risk. So
absolutely,
you need to have ongoing testing. So that's the thing now. That the guidelines are actually making it so that it's up to the discretion of the clinician to actually offer it to you, which means that it's not gonna like, how you just mentioned how like, oh, there's a set of questions that are like, just standard questions that everybody gets asked, right?
Yep.
There's questions around, like you said, like, substance use. There's questions around depression, right? We're trying to make the case with the work that I'm doing that there should be a standard set of questions around HIV exposures,
yes,
right, and HIV risk, and and COVID vaccines. And I'll tell you in a minute why we're kind of coupling those two. But without it, what we're really doing is we're maintaining stigma, because I literally did some interviews with patients, and they said that if their, PCP literally asks them for an HIV test, they would be offended. And the reason for that, and the reason for that is because right now it's not the standard of care. It's not a question that you just ask everybody. So if they did ask you, you may think like, well, what makes you want to ask me that? Because you don't ask everybody that. So what was it about me that so you feel profiled,
Yes,
so, so that's why we're saying, like, we already know there's a stigma associated with having these conversations, unfortunately. So take away the stigma by saying, you know what? These are a set of questions I ask everyone. And this is why it's really important. So I'm not just handpicking you, right?
Yes.
Everybody needs to have these conversations. And to your point, need to be honest. Because, depending on how you respond to these questions are the next step, like how your PCP is going to respond. Like, oh, okay, you know what? Because you said XYZ, so I think that you might be a good candidate for PrEP, or because you said, and that's why it's so important, because going back to your point about, oh, you're married. Marriage doesn't protect you from HIV.
It doesn't. Well, remember that was in that Tyler Perry movie with Janet Jackson.
Exactly. It does not protect you. Like, no. Like, so that's why I don't think that's why we want to take it out of the discretion of the PCP, because they may think, oh, look, this person is older. And again, age doesn't protect you either. People who are older in age can have very full, sex life. We're sexual beings. Like, there's no cap of like, oh, by this age, you're not having sex no more. That's not true. Right?
No, it's not.
So again, so age don't protect you. Marriage doesn't protect you. So like, if we use those as factors, what that's going to do is that's just going to contribute to bias.
Yeah.
Around like who's engaged in XYZ behavior. Just like, no. Take that off the table. And everybody is equally susceptible to HIV if you're being sexually active. And by the way, there's like a set of questions that it's really important to ask, because some people, going back to health literacy, like they think of sex in different ways, right?
Yeah.
So it's kind of like, when I say sex, what am I talking about? Like what goes where? What are you doing, right?
Yes.
Instead of just saying, oh, like, are you having sex? Because then people just think and respond to that differently, right?
They do. They do. You got to get real
You
specific.
got to get it. Yeah.
Like, are you exchanging bodily fluids
Basically.
in this way, this way?
Literally.
Are you entering any body part, whatever body part is your preference? Because you are right. People's definition of sex varies, and that's perfectly fine. It should, because it's a personal thing. Sex is personal. You touched on something about, talking to your PCP, talking to your nurse practitioner, whoever your healthcare provider is. How can Black people, when they go to the doctor, talk to their doctor specifically? What question, if there's one question they should ask their doctor, what should it be as it relates to HIV?
So I mean, that's a really good question around HIV. I would say that before we even think about like a very specific question about HIV, I think that it's more important to just back up and then just think about overall health, because your overall health actually is going to impact, because if you like, we know HIV, human immunodeficiency virus, is affecting your immune system, right? Yeah. So while we can narrow in on one specific viral infection or infectious disease, I think it's important to just overall just establish a relationship, a rapport with your PCP, and just get into the habit of just being open and honest about all the things that you're feeling, right? So for example, for me, back in the day, this doesn't happen to me anymore, but back in the day, I used to be like, oh dang, I forgot to say this or mention that, right? Yeah. Because you get caught up, especially if you come in for like a so-called like problem visit, like you're so focused on like whatever it is you came in for, you forgot to like bring something else up. So this is why I find it really helpful to like prepare before I actually go. And I literally put my thoughts or my questions in my phone. Like I have like like the notes app. And I was like, okay, don't forget to say this. Or, for example, if I notice like, oh, you know what, there's been a change in my sleeping habits. Like, I'm not sleeping throughout the night. Like in your mind, it's like, that's not a big deal, but it is. All the things, any change that you notice, bring it up.
Absolutely.
That's what they're there for. Because they be like, oh, actually, that might be an indication. So like all of this is like connected,
It is.
So bring up the fact that, actually lately I haven't been able to sleep through the night, or any change in your eating habits, or fluctuations in your weight, or, with women, the color and the change and the odor or the texture of your discharge, like any and everything. Like
all of it. All of it.
Yes. Headache, like any symptoms that you have, headaches, I'm fatigued, I'm lightheaded, like just bring it up and then let them decide, okay, it sounds like this, that, and the other. Because if you like withholding information, they don't have the full picture of what's happening. So they can't really like, share the prognosis, like, what, it sounds like XYZ. So you're going to help them out by giving them everything they need. Yes. And they'll be able to address that. Right. Yes. But, here we are, I mean, there is no HIV vaccine. Let's be very clear. Right. There are vaccines for other things like the flu, Mpox, COVID, So I think it's also really important, because I know people do have questions, especially in this COVID era that we're living in, about the science behind it, right? Like, what's in it and what level of protection does it offer? Like, how does it work? All like any and all of those questions. This is the place to get that question answered. Of course, you can look it up online, but nothing like taking, and again, I'm not gonna say don't look things up online, because I think that's really important to do research.
Absolutely. Oh,
but yes. Bring what you read, though. Bring what you were told. Bring what you know with you. You know what? Is this true? Because I thought, whatever. Yeah. That kind of thing, because it's important to get a second opinion, right? It is. It's not going to hurt to get a second opinion. To like I said, when it comes to taking charge of your health. Yeah. So again, I can't stress enough the importance of having what we call a medical home, like an actual PCP that knows you. Yeah. If you go to the ED, there's not going to be continuity of care there, right? Like you see a new person every single time. Like, and so we just need to use the ED in the way it was intended for emergencies, and actually go to a PCP for, like ongoing everything else. Yes. So that, again, like I said, they know all the things, like, oh, Matt, last time you mentioned this and then it, like these factors, like how any changes. So like those are the type of things that you just want to, pose those questions. So I would say I couldn't give you, this is the one question that you should ask. I feel like there's a host of questions, right? Because it really depends on your health status.
What's going on?
Yeah. So you need to just be forthcoming with like how you feel, and again, not waiting until you don't feel well to go. Like when you're feeling well, go, because you want to maintain the wellness. Absolutely. So I think that's just like the best way to kind of approach that.
And you touched on something there. Have a PCP before you get sick. So Sometimes we wait until, oh my God, I can't breathe, or I have chest pain, or I got a sore throat. We need to be getting into a PCP before we get sick. In some markets, some cities, depending on the health system, your health insurance, the population there, it might take 6 months to get in and establish with a primary care provider. And so it's so important that we establish that while we're healthy before we need them. So then when you do get that sore throat, when you do have vaginal discharge, when you do have a red eye, whatever is going on, any changes in your breast, you can call them, send them a My Chart message or electronic message and say, hey, something ain't right.
Yeah,
And then they're like, oh, okay, I know you, Susie, or oh, okay, Keisha, I already know you. Not, girl, you're not my patient. You
right.
know?
Right. No, literally. Right. And these days, it's like, I'm glad you brought up the electronic health record, because that's like, now we can send messages directly to your PCP, and there's telehealth, right?
Yes.
So you don't really have to get up and go somewhere. You can so there's like all these ways that there has been more and more efforts
Yes.
to increase access. So it's not just like you say, got to wait all these months to like see them,
Yes.
sometimes you need to come in. Like, it's just, I have this question and I want to, or I need a, sometimes, like, for example, for me, like I need refills on like prescriptions. I don't even got to go in. I just click a button when I open up my patient portal, refill. Literally that same day, CVS called me like, it's ready. I'm like, bet. You know what I'm saying?
Yes.
So
I
like,
just had a
yeah.
telehealth visit with my PCP for a small issue last Thursday, and I needed to travel for family, and they were like, she can get you at 9:30. I said, I have hotspot on my phone and I have my laptop in the trunk. And I took that call right in that driver's seat. I pulled over, parked, and she said, are you in the car? I said, yes. And I turned up the lights. She said, the lighting's funky. I turned up the lights in the car, turned on all the lights, and I leaned into that camera, and she got me together. The call took maybe 5-10 minutes max. And I got what I needed. She called in the prescription, and I was back on the road good. I was like, send it to the pharmacy by my mama's house.
Right.
Because that's where I was traveling to. And it was all click, click, click. It's just as easy as making an IG post.
Literally. Right. And that only happens when you have a PCP.
Yes. You can't do that if you just don't have a PCP or just pop up in the emergency room. Like, no, that's not how it goes. So something you touched on earlier, Dr. Ward, is some of the successes, some of the advances in HIV care. Can you talk a little about that so we can celebrate that?
Yeah, I actually appreciate this question, because I feel like we often focus on the challenges, and we don't and gaps and things like
What's
that.
broke?
Literally. So yeah, I'm gonna mention some things, like kind of nationwide, but since I live in DC, I want to go ahead and start here. So I'm unsure if you actually remember, but back in 2007, we were literally at the epicenter of an epidemic in DC.
No, I don't recall that.
Literally 1 in 20 adults had HIV. That's how saturated the city was with HIV.
Wow.
But because of that, though, lots of resources were funneled, our way. And then we really became like kind of innovative in our interventions. So one of those innovative interventions was the fact that we've routinized HIV testing in the ED. So no matter which room you go to in the city, you're automatically getting tested for HIV.
Awesome.
It doesn't matter what you came in for, you're getting tested. And I love that, actually. And I think that, that's a model that, first of all, should be expanded into primary care. Because, there's only the keys, but, and that's because it gets a large gamut of people, right? Because like I said, a lot of people go to the ED because, you will not ever be turned away to, for care in the ED.
Yeah.
So, like I said before, it removes the stigma from profiling specific patients. Oh, you got risk, and like, nope, it's standard care, everybody getting it.
Yeah.
And same thing happened with pregnant women, right? It's like it's standardized HIV screening for all pregnant women, not just in ED, but if you whatever healthcare setting you're going to get that. And what that's done in DC has nearly eliminated mother to baby transmission.
I love it.
Exactly. So we know that, screening and testing works, right? When people know their status, and you can usher them in and get them into to care.
Yes.
But during the COVID pandemic, DC actually focused on housing as prevention. So you may be like, housing as prevention? What? Remember how the social determinants? Remember?
Yeah.
at the end of the day, if you worried about like where am I gonna sleep tonight, the last thing you're gonna be thinking about is HIV prevention.
Yep.
Right.
Yep.
So if when people need stability, like they need their basic needs met. So what happened was that DC, we piloted this program for men who have sex with men that provided them with workforce development, stable housing in exchange for them agreeing to stay on PrEP. Again, the daily pill that HIV negative people take to stay negative. Yes. And they found there was 100% compliance and uptake of PrEP. Like nobody missed their pill. They took it every single day. And that's because they didn't have to worry about where they were going to sleep.
Yeah. Yeah.
So literally it's housing as prevention.
Yeah.
And you can take out housing and put in like other things, employment. You can take out employment and put in community safety, like all of the in terms of health. These are the basic things that people need, because those get a priority over PrEP and condoms. And you know what I'm saying? Those things are important, but these are larger macro, like the conditions that you live in. Yeah. And that makes it, that much harder for you to, prioritize or even care about that when you feel like, okay, I don't know what I'm going to eat. I don't know what I'm going to say. I don't feel safe. Like those are you think about Maslow's hierarchy of, of needs.
Yep.
But nationally though, like I said, across the board, HIV medications are super, super, super effective. Remember back in the day, anybody with HIV had to take what was called a cocktail of pills, right?
Yep.
And they weren't even like, useful in keeping your viral load down. It was just like trying to prolong your life before you advance to AIDS. But now people just don't even need to ever get AIDS. Like at this point, we're like, like in the US, the like cases of AIDS, except in the South, unfortunately, people are advancing to AIDS, and that's a whole other conversation.
That's a different conversation in the South.
Exactly. But you don't have to if you have access to treatment. Literally these days, HIV is like a chronic condition, right? It's like if you're not even transmitted to anybody because your viral load is so low, it's not even detectable. So like people with HIV these days, they're living long lives and they end up dying from other things like, kidney disease or cancer. Not HIV though. Right? Because they're taking their meds. And this is why people believe the myth that Magic Johnson's been cured. It's like, no, you believe that, he ain't got no more because he got money and they got a cure in the back. It's like, no, there's no cure for HIV, right? Like he literally is a poster child for how wonderful HIV meds work. Yeah,
I was going to talk about him. Like, what about Magic Johnson though? Exactly. Because we talk about Magic Johnson like the golden child of HIV survival.
Yes. But that's why though, it's HIV meds. Take your meds and you too will be good, right? Yeah. Same with PrEP, if you take your PrEP, which is super effective, it does keep HIV people, HIV negative people negative. But that's the thing, of all the groups, Black women have the lowest uptake of PrEP. And it's a combination of, like I said, not being offered it. You know what I'm saying? And then, and there's like some other factors, but we think about like the cost of PrEP and things like that. There's other kind of, factors, barriers.
Systemic things.
Yeah, systemic factors. Yeah, systemic factors.
You talked about standardizing HIV care in the ED. And when you said that, it made me think about how when you go to the ED or you go to a PCP, a specialist, if you interact with any healthcare provider, 99.999% of the time, they are going to take your blood pressure, even if it's the dentist, and they're going to ask you if you smoke. And there was a time when they didn't screen people for tobacco use. Yeah. That's been in my lifetime. And so if we take people's blood pressure, it catches it catches high blood pressure. And sometimes people get sent to the ED right away from the dentist's office, their OBGYN, whatever. Whoa, this blood pressure, you got to go to the ED. And then if you smoke, they may offer you some interventions on that. But then if we added HIV screening as that standard, because now people are not offended when they say, do you smoke? We're not offended. Or when they say, I got to take your blood pressure. I just went to the dentist the other day and they took my blood pressure. It was just for a cleaning, but it's so standard now that we don't even think about it. And if we did that with HIV testing, that would almost eliminate the stigma, and screening numbers would be close to 100% of people who interact with the healthcare system. Right.
Because that's the best. You gotta be there in order to get it.
Yes. Well, what else can you share with us, Dr. Ward, before we do some rapid fire questions about your work and anything that you especially want Black women to know about HIV and their risk?
Well, I would say that as far as my work is concerned, earlier I just briefly mentioned that, I'm really trying to promote the importance of routinizing or making HIV screening the standard of care, but I'm also doing that for COVID vaccines. Now, It may not be intuitive of like, why HIV and COVID, right? Like, what do those two have in common other than the fact that they both, are infectious diseases and, spread by a virus.
Yeah.
The fact that they both are highly stigmatized.
Yeah.
And they both disproportionately impact the same patient populations.
Yeah.
Black and brown people and those who identify as LGBTQIA, right?
Yeah.
And so if we, take these two conditions and, and say, let's create screening questions so that, like we said, it removes the stigma.
Yeah.
And just be like, okay, you know what? Let's have a conversation about, again, we hadn't talked about COVID, but we need to talk about COVID vaccines as well. And just making that the standard of care of like, okay, I'm going to go ahead and add in like the last date of your COVID vaccine. And like, oh, wait, I didn't have a COVID vaccine. Okay, then that's your entryway to be like,
yep.
Okay, let's go ahead and talk about it. You know what I'm saying? Or like, oh, maybe they did have it, but you didn't get your booster. You know what I'm saying? So just like any the vaccine where you want to be up to date and I want to update your electronic health record when the last time you had it, that's what we're doing, right? And the same thing with, with HIV. It's kind of like, a set of questions and then you can get a test, set of questions, you can get prep, right? So that's what we're going to do that just across the board. And that's really important, like I said, because Black women, especially when it comes to HIV, we're disproportionately impacted. We don't need to be.
Right. We don't.
We just do not need to be. If we address some of these systemic structural issues, then the rates would dip.
Yep.
Most certainly. So I think that, because it's nothing unique to being a Black woman. Like, it's not that. It's like I said, all the other factors. So let's address those other factors. And then that way, we would have we would have more opportunities for health.
Absolutely.
Yeah.
That's a great answer and wrap up, and a great segue to some rapid fire questions. So my first rapid fire question for you, Dr. Ward, is what does wellness mean to you?
Wellness is when you tend to your whole self. To me, it's like, yes, your physical body, but it's also your mental and your emotional and your spiritual, social, cultural, and financial self.
Yes.
Ooh, right.
Yes.
So like, I'm committed to, lifelong learning. And so I'm always thinking about, okay, what education and resources and skills, can I lean into, and what are the education and resources and skills that I still need? Yes. And the reason why that's important is because there's a podcast for that. There's an app for that. There's a friend or a prayer for that. There's a therapist for that. There's a financial planner for that. That's real. So, let me just talk about financial real quick, because maybe people are like, financial, what does that got to do with wellness? Everything. What?
Everything.
If you're anxious about money, if you're mismanaging money, it's going to affect your mental and your physical. Like,
absolutely.
Losing sleep, like your edge is gone, like
all the way gone.
Like, how am I gonna pay for this? How am I gonna save for that? It's like, okay. And that's why I love the World Health Organization's definition of health, because they say health is not merely the absence of disease, right?
It is not.
Psychosocial and mental aspect of life that weighs in on us. So that's why I say health is the whole stuff. All
the way. Why is Black health literacy important?
Oh my God. So
that's a big one.
Oh my God. I love Black Health Lit. Okay. I love that. I love people like you captured like Black Health Lit. Okay. So first of all, overall health literacy is important, right?
Absolutely.
So much so that attaining health literacy is actually part of our nation's Healthy People 2030 goals. I don't know if you know that. But you can be literate and not be health literate. Right.
That's facts.
So this does call for our ability to just wade through all the information that we have, get access to and make sense of it. Mm-hmm. We have so much information at our fingertips that it can be overwhelming if you don't know sources to trust. So when we read something, we need to be able to process that, apply it to our life, weigh the risk and the benefits, understand and interpret data, and then act on it. So I think this is especially important for Black people and Black women, because like I said, we're disproportionately impacted by racism and bias and discrimination and stigma, which is leading to the health disparities that we're facing. So it's not squarely our responsibility alone, but we do have a role in our health. So this is the need for Black Health Lit.
Yeah, Absolutely. And how can people connect with you, learn more about your work? It sounds like you're doing some great things.
Yes. Well, I would love for people to learn more about the national training model that I'm leading for PCPs to make HIV screening and COVID vaccine screening the standard of care. So we do call that 2-in-1 because it's a dual screening in the primary care setting. So people can visit my website. It's 2-in-1, so it's no numbers. It's all letters, 2-in-1.
Spelled out. Yep.
Yes. SMHS, which is School of Medicine and Health Sciences, GWU, which is George Washington University, .edu.
Yeah. Okay.
And they can also follow me on LinkedIn. My name is Maranda Ward, all A's in my name. So I felt really excited when I saw the flyers and you had all A's. I was like, oh,
yes, spell it right. Get it right.
Okay. You can also follow me on Twitter at Doc Maranda Ward. Again, all A's.
Yeah.
So, thank you for that and for the invitation for folks to stay connected to me.
Absolutely. And thank you so much for educating us today. My very first guest to talk about HIV, such an important topic that is impacting Black women. You all heard the statistics. So please, please, please talk to your PCP about your HIV risk. And thank you, Dr. Ward.
Thank you.